Hello, my name is Shubhayan Sanatani, and I'm delighted to be here with my two colleagues, Dr. Susan Etheridge and Dr. Ian Law, to talk to you today about a new way to look at Wolff-Parkinson-White Syndrome. And I'm delighted that the three of us have been recognized with an Arrhythmia Alliance Pioneers Award and in the realm of SVT Pioneers. And we're very grateful to the Arrhythmia Alliance for this recognition. Now, the three of us are here today really representing a larger group. We're all members of the Pediatric and Congenital Electrophysiology Society, or PACES, and we've all served as president of the PACES Society in the past. And so we're very privileged to be speaking really on the work that all of that society has been doing. So with that said, let's talk a little bit about our new look at Wolff-Parkinson-White syndrome. So as with most things in our clinical realm, a case always highlights the importance of the issue. And here we're talking about a previously 14-year-old who was just playing basketball at school. It wasn't a particularly strenuous, it was just a practice, and they were shooting some, and doing some drills. Then he felt his heart rate increase, but he felt all right, and he kept playing. And this was a very familiar sensation to him. He'd had it, as long as he could remember. So he thought this was just him and normal exercise. He'd never actually been checked out by a doctor. Now, after the practice, he's not feeling as good, and he starts to feel a bit dizzy, and then sits down for a rest. And people notice, a couple of teammates tease him because he was a bit more winded, and he didn't look that good. And then people realize, wait a sec, he's not kidding around, and he's getting a bit confused at that point. And then they quickly get the coach and the trainer over to activate emergency services. And thankfully they were somewhere where they had a quick response, and they got him into the hospital quite promptly. And when they hooked him up to the monitors, even at the triage, they knew something was going on with his heart. And this is a tracing that no one likes to see in their clinic or in their emergency department. This is a very wide, complex tachycardia. The rate is as fast as 300 beats per minute at times. And there's two things that are striking. One is that it's very irregular. So one can't help but say this is irregularly irregular. There's a pattern. There is no pattern. It's also very wide. And so there are areas where one would look and really consider this to be a polymorphic ventricular tachycardia. And there are portions of this where one might say, oh, I wonder if this is something like Torsade or some sort of polymorphic ventricular tachycardia. Now, the big tip off, of course, this is a 14-year-old boy who was well a few hours ago and who's had similar symptoms lots of times. So this, as we know, is what's called pre-excited atrial fibrillation. And this is something that's very specific to Wolff-Parkinson-White. So we'll just step back a moment. Now, Wolff-Parkinson-White is named for the three individuals that wrote an eponymous paper in 1930. The syndrome had been recognized before that time even, but these individuals put together a nice series of patients who had the classic ECG findings of a delta wave and this heart racing, or so-called arrhythmia, or what we now know is supraventricular tachycardia. Now, what we still haven't figured out almost 100 years down the road is, why do patients with Wolff-Parkinson-White develop atrial fibrillation? And as our audience will know, atrial fibrillation is an extremely common arrhythmia problem occurring in 10% of the aging population. And that is also multifactorial. But the atrial fibrillation in Wolff-Parkinson-White is different from that and occurs in the absence of these other risk factors. Now, because of the existence of this accessory pathway, the rapid atrial activity can be transmitted to the ventricle and effectively result in ventricular tachycardia or ventricular fibrillation, as we saw in that ECG. Now, we've been talking about this since it was recognized as a complication, but the amount of data, especially pediatric data on this, is very limited. Now, we have now a good understanding. Here's a section from a heart that shows an accessory connection. And here is a tracing again of Wolff-Parkinson-White. This one's not quite as irregular, but definitely indicates the rapid atrial rhythm that then can be conducted through the accessory pathway to the ventricle. And in the worst case scenario, the ventricle will not cope with this and develop ventricular fibrillation. So about 11 years ago, in the Pediatric and Congenital EP Society, we became a bit more organized about our approach to supraventricular tachycardia, including Wolff-Parkinson-White syndrome. So I'll turn it over to Dr. Law to talk a bit about how we became a bit more organized in our approach.
Thank you, Shu. And I want to again express my gratitude for being a part of this Arrhythmia Alliance Health Care Pioneer group. And once again, we represent a much larger population. And as Shu pointed out, this was described back in 1930, but we are learning so much more about this. And I was part of a group of people from the Electrophysiology Society that wrote a consensus document to try to better determine how we approach Wolff-Parkinson-White syndrome. And in this case, this is someone, and the focus of this paper was on if someone comes into the emergency department, maybe they have chest pain and they get an EKG and their EKG shows what appears to be Wolff-Parkinson-White syndrome. Now, we called it asymptomatic Wolff-Parkinson-White syndrome, which is a bit of a misnomer because in order to meet the criteria for Wolff-Parkinson-White syndrome, you have to have palpitations or the sudden onset tachycardia. And in this case, they don't have that, so they don't meet the criteria, but they are presumed to be at risk because, as we pointed out before, 20 to 30% of the people that have the Wolff-Parkinson-White syndrome were asymptomatic before they had their event. So the focus of this paper was to determine if you have this EKG that shows ventricular pre-excitation, how do you best approach that? And it was a consensus document, and we went through the literature and developed some guidelines. But those guidelines were based upon adult literature and a small case series on the pediatric side. So we needed to do a better job on gathering data. And this led us to develop a more prospective analysis and tap it into the tremendous efforts of the PACES Society. And as a side note, in order to do these studies, we often in pediatrics, we do these unfunded studies. But I happened to come across a friend now, but at the time is the father of a son who had Wolff-Parkinson-White syndrome, who died suddenly. And as Shu pointed out that in that case series or case study, it's just a person, is a random person, a 14-year-old that had this disease. But in this case, this was Paul's son, Matthew, who had been diagnosed with Wolff-Parkinson-White syndrome. And he was an active hockey player, enjoyed playing guitar, which is why we have this rock for the heart symbol up here. And he went to bed one night and he woke up, and he never woke up again. And for Paul, as any parent would express, it was devastating. And he'd had Wolff-Parkinson-White syndrome on his EKG, but he'd never had any palpitations. And he was one of that 20 to 30% of the people that had an event, but had no really precursor, no red flag per se, other than an abnormal EKG. And so Paul and I came in contact, and Paul said, I don't want this to happen to another child. How do we make sure this doesn't happen to another child? And once again, I put a name on a disease, because we often read about diseases, but this humanized this disease. And Paul was incredibly dedicated. So he helped fund many of these studies that we're going to talk about now. And I'm going to pass the baton to Susan, who was key in utilizing this money from this foundation to get prospective and retrospective data.
Thank you, Ian. And again, thank you to the Arrhythmia Alliance. Years ago, we did a retrospective assessment of risk of children with Wolff-Parkinson-White syndrome, and we found out it was higher than expected. That retrospective study, however, was somewhat enriched for people who died suddenly. And although published and probably important in changing how we care for these patients, people thought we should do something that was more forward-thinking or prospective. So as you can see, it takes a village. And with this village, we have an ongoing prospective assessment of children with Wolff-Parkinson-White syndrome. And how rare are their events really? So we did do a retrospective study of Wolff-Parkinson-White children, and we found out that the risk was actually higher than previously thought, and probably higher than in the adult population. Although that study was published and probably did change how we manage these patients, people thought we needed a more prospective or forward-thinking study. So we have an ongoing study with 19 participating centers in the US, Canada, and India. And we're submitting prospective data on children less than or equal to 21 years of age who have Wolff-Parkinson-White syndrome. And we're looking at everything about them to help us try to predict who is at risk. And then we're also comparing children who have WPW who have had a life-threatening event to those who have not had a life-threatening event. And we described a life-threatening event as sudden death, where we have enough data, an ECG or other data, to know they had Wolff-Parkinson-White syndrome. Aborted sudden death, so that they had an event, but they were resuscitated, and we have all of their data. Or pre-excited atrial fibrillation, which are what ECGs you've seen to date, those wide QRS, fast, irregular rhythms, where there's a rapid conduction. That's what a Sperry of less than or equal to 250 milliseconds means, or they faint or have hemodynamic instability. So this is our high-risk group, and we're going to compare that group to the patients who just have WPW and see if we can untangle who is at risk. To date, we have 990 subjects. I thought I'd wait till we were at about 1,000 before we really started to do the statistics. The median age of the patients is 12. We have 19 subjects, or 2% of the total population, who've experienced a life-threatening event. They were more often male. Only about 1% of them had congenital heart disease. A few had cardiomyopathy and LV dysfunction. And there were a group who had intermittent pre-excitation. At present, we only know about these 2%. We haven't compared all of the data yet, so hold for further information. I did present the data to date with the 2% of the high-risk group. So in this group, in this prospectively enrolled cohort of children with WPW, life-threatening events occurred in 2%. It was the sentinel symptom in 50%, meaning half of this 2% of patients had never had a palpitation, an episode of syncope, or a documented arrhythmia before. So their first event was a life-threatening event. And in half of those, it was death or aborted sudden death. The life-threatening event occurred at rest or during routine activities in more than half. People think if you have WPW, maybe you can make this patient at less risk by restricting physical activities, but our data would suggest, just as in Paul's son, that these patients also die at rest. Importantly, if they had an aborted sudden death or life-threatening event that was a pre-excited atrial fibrillation, they typically had full recovery. So in this prospectively enrolled group, life-threatening event subjects had EPS-derived characteristics that would suggest they're at higher risk. So looking at an EP study would be helpful. Interestingly, most of our pediatric patients undergo their EP studies under general anesthesia, which probably changes in some way the characteristics of their pathway and may actually look like less risk. But interestingly, the group that had a life-threatening event were less likely to have general anesthesia than the other group. So we're still trying to work out what the role of anesthesia is in this population. And in all of these patients, ablation was safe and it was successful. There were very few risks and the success rates were over 90%. So there is ongoing work. This study is ongoing. We also would really like to know how safe is intermittent pre-excitation. So in some patients with Wolff-Parkinson-White syndrome, some of their beats in sinus rhythm look normal and some look abnormal. And people have thought to date that those patients are probably not at risk, but our data would suggest that they may have some risk. We're ongoing looking at algorithms to better assess pathway location, and then still working on trying to figure out what is the real role of EP study in risk stratification in this population. Thank you.
Well, thank you all. I think it was very good of the Arrhythmia Alliance to acknowledge this this work, and lots of work still to do. And thank you to my collaborators, Dr. Susan Etheridge and Dr. Ian Law. And we look forward to presenting more of this work as we learn more.